Good morning once again, my dear colleagues, intensivists battling at the bedside, fellow clinical pharmacists holding the pharmacotherapy line, and our esteemed professors shaping tomorrow's minds. Picture this, 4 o'clock in the morning. A crashing septic patient arrives. 12 intravenous infusions already running. Electrolytes dancing dangerously. Yesterday's home medicines unknown. Renal function crumbling by the hour. In that precise moment, the difference between chaos and control very often rests not merely on the ventilator settings or the next vasopressor dose, but on the quiet, precise, evidence-guided hand of the critical care clinical pharmacist. Today we return to that high-stakes world inside our largest ICUs. We shall walk, step by deliberate step, through each of the 22 cornerstone activities that define our unique contribution. Not in vague generalities, but with the granular detail. The real-world examples, the landmark trials, the hard-won protocols, and the subtle traps that only reveal themselves after years at the coalface. So settle in, make yourselves comfortable, perhaps refresh that coffee, because over the next few minutes, we are going deeper, much deeper, into the art and the science of what we actually do when lives hang in the balance. We start, as is only right, with the very first safety net, enhanced, expanded, and enriched. Activity number 1 is medication reconciliation. Medication reconciliation is the cornerstone of safe ICU transitions. It begins immediately upon patient admission to the ICU. Gather the patient's complete home medication list from multiple sources. Cross-reference with electronic health records and previous admissions. Identify any discrepancies, such as omitted chronic therapies. Verify drug names, doses, frequencies, and routes meticulously. Document all allergies, including severity and reactions. Intolerances, like gastrointestinal upset from NSAIDs, must be noted. Consult the patient's primary care physician or community pharmacist if histories are incomplete. Involve family members for insights on over-the-counter supplements. Herbal remedies, such as St. John's wort, can interact with ICU drugs. In large hospitals, high turnover demands streamlined processes. Utilize barcode scanning for inpatient medications to enhance accuracy. Employ standardized reconciliation forms or checklists from ICMP guidelines. Involve multidisciplinary teams. Nurses confirm administration, physicians approve changes. Reconcile at every care transition, including to step-down units. Post-reconciliation, monitor for unintended consequences like withdrawal. Educate residents on common pitfalls, such as look-alike drug names. Research from the Joint Commission shows reconciliation reduces errors by up to 70%. In septic shock cases, ensure beta blockers from home are not abruptly stopped. For elderly polypharmacy patients, prioritize deprescribing high-risk agents. Handle language barriers with translation services for accurate histories. Integrate AI-assisted tools for initial screening, but always human verify. Conduct quarterly audits to measure reconciliation completeness. Train on electronic systems like Epic or Cerner for seamless documentation. This activity fundamentally prevents adverse drug events in vulnerable patients. Now, advancing to an expanded activity 2, drug dosing adjustments. Critically ill patients exhibit profound pharmacokinetic alterations. Organ dysfunction, like acute kidney injury, necessitates dose reductions. Calculate creatinine clearance via Cockcroft-Gault or CKD-EPI formulas. For drugs like gentamicin, extend intervals in renal impairment. Hepatic failure impairs metabolism. Reduce doses of lidocaine accordingly. In cirrhosis, consider Child-Pugh scores for adjustments. Obesity alters volume of distribution. Use adjusted body weight for aminoglycosides. Hypoalbuminemia increases free fractions of drugs like phenytoin. Apply Bayesian pharmacokinetic modeling for vancomycin optimization. In ECMO circuits, drug sequestration requires higher initial doses. Pediatric patients demand weight or surface area-based calculations. Neonatal ICU adjustments account for immature enzymes. Elderly pharmacokinetics involve reduced clearance. Start low, go slow. Drug-drug interactions, like rifampin induction, accelerate metabolism. Frequent laboratory monitoring every 12 to 24 hours guides iterative adjustments. Therapeutic failures often arise from unadjusted subtherapeutic dosing. Toxicity, such as ototoxicity from aminoglycosides, must be preempted. In academic centers, simulate cases using software like Phoenix with Nonlin. Research in critical care pharmacokinetics informs guidelines like those from SCCM. Implement unit-specific protocols for vasopressors in shock. Collaborate with nephrologists for continuous renal replacement therapy dosing. Adjust sedatives like midazolam in liver failure to prevent accumulation. Monitor for augmented renal clearance in young trauma patients. Educate on pharmacogenomics, like CYP2C19 variants affecting clopidogrel. This ensures precision medicine in dynamic ICU environments. Proceeding to a more detailed Activity 3, Therapeutic Drug Monitoring. Therapeutic drug monitoring optimizes drugs with narrow therapeutic indices. For vancomycin, target trough levels of 15 to 20 milligrams per liter in serious infections. Peak and trough sampling for aminoglycosides prevents nephrotoxicity. Digoxin levels should be 0.5 to 2 nanograms per milliliter in heart failure, sampled 6 hours post-dose. Free phenytoin monitoring is essential in hypoalbuminemia, correct with formulas. Lithium levels aim for 0.6 to 1.2 millimoles per liter, with toxicity above 1.5. Tacrolimus troughs of 5 to 15 nanograms per milliliter in transplant patients prevent rejection. Sample timing is crucial. For cyclosporine, trough just before dose. Interpret results alongside clinical status, like infection resolution. Adjust doses using nomograms or pharmacokinetic software. In ICU instability, monitor levels more frequently, up to daily. Academic centers pioneer TDM assays for emerging drugs like monoclonal antibodies. Train staff on proper venipuncture to avoid hemolysis affecting results. Utilize point-of-care testing for rapid theophylline monitoring in asthma. Correlate serum levels with clinical outcomes, such as seizure control. Manage supratherapeutic levels with interventions like hemodialysis for lithium. Address subtherapeutic levels by increasing doses or frequencies. Research from ASHP highlights TDM's role in reducing hospital stays. In obese patients, consider total body weight for level interpretations. Handle drug assays interfered by bilirubin in jaundiced patients. Integrate TDM with electronic alerts for out-of-range results. This dynamic approach maximizes efficacy while minimizing harm. Onward to Activity 4, Antimicrobial Stewardship. Antimicrobial stewardship preserves efficacy against rising resistance. Base empiric therapy on local antibiograms and patient risk factors. For MRSA suspicion, initiate vancomycin promptly. De-escalate to narrower agents once cultures and sensitivities return. Set evidence-based durations, 7 days for uncomplicated pneumonia. Monitor for adverse effects like Clostriditis difficile colitis from broad-spectrum use. Promote beta-lactam alternatives over fluoroquinolones to curb resistance. In septic shock, stewardship ensures timely, appropriate antibiotics. Collaborate closely with infectious disease consultants for complex cases. Educate ICU teams through weekly stewardship rounds. Track institutional resistance patterns via surveillance programs. Implement electronic order sets with built-in stewardship prompts. Restrict high-risk antibiotics like carbapenems via approval processes. Research stewardship's impact on mortality as per IDSA guidelines. Apply principles to antifungals, echinocandins for candidemia. For antivirals, monitor resistance in influenza or CMV. Prophylaxis regimens in neutropenic patients, balance risks. Audit compliance with bundles like the Surviving Sepsis campaign. Handle polymicrobial infections with combination therapies judiciously. In academic settings, mentor fellows on stewardship research. This global imperative safeguards future antimicrobial utility. Next, a deeper dive into Activity 5, Pain and sedation management. Pain assessment employs tools like the Critical Care Pain Observation Tool. Titrate intravenous opioids such as fentanyl for acute pain control. Monitor respiratory rate and capnography to detect depression. Incorporate multimodal analgesia with acetaminophen or ketamine. Short-term sedation favors propofol for its rapid offset. Dexmedetomidine offers alpha-2 agonism, sparing ventilation. Implement daily sedation vacations to assess neurological status. Utilize the Richmond Agitation Sedation Scale for goal-directed therapy. In mechanically ventilated patients, synchronize sedation with weaning trials. Academic research validates protocols reducing ventilator days. Address opioid tolerance with rotation to hydromorphone. Integrate non-pharmacological interventions like music therapy. Vigilantly monitor for delirium using ICU. Manage withdrawal with tapered regimens or clonidine. In post-surgical pain, consider regional blocks alongside systemic drugs. Educate families on the balance between comfort and alertness. Research links oversedation to prolonged ICU stays. Handle special populations, like burns, with higher opioid needs. This ethical management prioritizes patient-centered care. Now, we will progress to Activity 6, Nutrition Support. Nutritional assessment includes anthropometrics and serum markers like pre-albumin. Calculate energy expenditure with equations like Harris-Benedict or indirect calorimetry. Prefer enteral nutrition via nasogastric tubes for gut integrity. Initiate parenteral nutrition only when enteral is contraindicated, like in bowel obstruction. Customize total parenteral nutrition with appropriate dextrose, amino acids, and lipids. Daily electrolyte monitoring prevents imbalances in TPN patients. Gradual initiation averts refeeding syndrome in malnourished individuals. In hypermetabolic states like major trauma, increase protein to 1.5 to 2 grams per kilogram. For obese patients, opt for hypocaloric, high-protein feeding. Research micronutrients roles, such as zinc in wound healing. Collaborate with registered dietitians for holistic plans. Ensure admixture compatibility, avoid calcium phosphate precipitation. Tight glucose control with insulin in nutrition therapy. Monitor triglycerides in lipid emulsions to prevent hyperlipidemia. In academic centers, study immunonutrition with glutamine or arginine. Handle gastrointestinal tolerance with prokinetics like metoclopramide. This vital support accelerates recovery and immune function. We will now discuss Activity 7, Electrolyte and Fluid Management. Serum electrolytes warrant monitoring at least twice daily in unstable patients. Hypokalemia correction uses intravenous potassium to prevent ventricular arrhythmias. Magnesium repletion is key for refractory hypokalemia or torsade de Poor. Hyponatremia management distinguishes SIADH from hypovolemia. Slow sodium corrections mitigate risks of central pontine myelinalysis. Fluid balance tracking employs input-output charts and daily weights. In septic shock, crystalloids like lactated ringers are first line. Colloids such as albumin are considered in hypooncotic states. Hyponatremia from loop diuretics requires free water administration. Academic debates favor balanced crystalloids over normal saline for acidosis prevention. Phosphate replacement in diabetic ketoacidosis averts respiratory failure. Calcium adjustments in acute pancreatitis address hypocalcemia. Educate on iatrogenic causes, like citrate from blood products. Monitor acid-base status with arterial blood gases. In large hospitals, protocols standardize massive transfusion electrolyte handling. This maintains physiological homeostasis amid critical illness. We will now focus on Activity 8, Anticoagulation Therapy. Venous thromboembolism prophylaxis employs subcutaneous low molecular weight heparin. Therapeutic anticoagulation for pulmonary embolism uses weight-based heparin infusions. Monitor activated partial thromboplastin time for unfractionated heparin efficacy. Direct oral anticoagulants suit patients with stable renal function post-ICU. Reversal agents include protamine for heparin or idarosizumab for dabigatran. In extracorporeal circuits like ECMO, titrate to antifactor 10A levels. Academic trials evaluate bivalirudin in heparin-induced thrombocytopenia. Educate on perioperative bridging with low molecular weight options. Manage bleeding complications with transfusions and vitamin K. Handle obesity with adjusted enoxaparin dosing. This prevents devastating thromboembolic events in immobilized patients. Let's now focus on Activity 9, Drug Interaction Screening. Daily screening of all medications identifies potential hazards. Cytochrome P450 inhibitions, like ketoconazole with statins, risk rhabdomyolysis. QT interval prolongation occurs from combining haloperidol and amiodarone. Utilize interaction databases such as Micromedex or UpToDate. Mitigate by substituting safer alternatives like switching antifungals. In polypharmacy ICUs, continuous infusions amplify interaction risks. Research quantifies interaction prevalences in critical care cohorts. Implement electronic alerts to flag high-severity interactions. Educate multidisciplinary teams on pharmacokinetic versus pharmacodynamic interactions. This proactive vigilance circumvents avoidable patient harm. We will now progress to Activity 10, participation in multidisciplinary rounds. Daily attendance at bedside rounds integrates pharmacy perspectives. Offer real-time recommendations on drug selection and monitoring. Facilitate discussions on de-escalation or discontinuation. Enhance communication among physicians, nurses, and therapists. In academic environments, use rounds for teaching pharmacology pearls. Research demonstrates rounds reduce medication errors by 50%. Foster a culture of collaborative decision-making. This elevates overall ICU care quality. Now we will look at Activity 11, Adverse Drug Reaction Monitoring. Continuous surveillance detects emerging adverse reactions promptly. Employ causality assessment tools like the Naranjo algorithm. Manage reactions by immediate cessation or dose attenuation. Report serious ADRs to national systems like FDA MedWatch. In large academic centers, analyze institutional ADR patterns for trends. Educate staff on early recognition signs, such as rash from antibiotics. Research ADR epidemiology to inform safer prescribing practices. This bolsters pharmacovigilance and patient safety. Next, we will discuss Activity 12, Pharmacokinetic consultations. Consults apply absorption, distribution, metabolism, and excretion principles. For obese patients, hydrophilic drugs dose on ideal body weight. Elderly exhibit reduced hepatic clearance, halved doses of benzodiazepines. Organ failure prolong half-lives, space intervals for beta-lactams. Utilize simulation software for scenario predictions. Academic pharmacokinetic labs advance models for critically ill. This tailors therapies to individual patient physiologies. Let's now talk about Activity 13, IV compatibility and stability assessments. Assess Y-site compatibilities for co-infusions. Prevent chemical precipitations, like with ceftriaxone and calcium. Evaluate stability in various diluents over time. Use reference resources like King Guide or Trisel stability of compounded formulations. In complex multi-nime setups, sequence administrations carefully. Research novel compatibilities for emerging therapies. This guarantees safe and effective intravenous delivery. We will now advance to Activity 14, Code Blue and Emergency Response. Rapid response to cardiac arrests involves algorithm adherence. Administer adrenaline every 3 to 5 minutes in asystole. Titrate vasopressors like noradrenaline for post-resuscitation hypertension. Provide antiarrhythmics such as amiodarone in ventricular fibrillation. Oversee post-code care, including targeted temperature management. Train in advanced cardiac life support protocols annually. Research optimizes emergency pharmacotherapy protocols. This intervention is life-saving in acute crises. We will now shift gears to Activity 15, Cardiovascular Pharmacotherapy. Heart failure management includes ACE inhibitors like lisinopril, ramipril, perindopril, and enalapril. Arrhythmia control is achieved with intravenous amiodarone loading. Hypertensive crises is treated with titratable nicardipine infusions. Inotropic support is done via dobutamine in cardiogenic shock. Hemodynamic monitoring guides therapy adjustments. Academic cardiovascular trials inform evidence-based choices. This stabilizes vital circulatory functions. We will now progress to Activity 16, Neurological drug management. Seizure control employs loading doses of levetiracetam. Intracranial pressure reduction is achieved with hyperosmolar mannitol. Acute ischemic stroke thrombolysis is done with alteplase or tenecteplase within windows. Traumatic brain injury sedation avoids propofol infusion syndrome. Monitor for drug-induced neurotoxicity like from cephalosporins. Research neuroprotective agents in ongoing trials. This safeguards neurological integrity amid insults. Let's now discuss Activity 17, Endocrine and metabolic support. Hyperglycemia is managed with continuous insulin infusions. Hydrocortisone is administered in refractory septic shock for relative adrenal insufficiency. Thyroid hormone replacement is used in myxedema coma. Bicarbonate is used for severe metabolic acidosis in select cases. Cortisol level assessments guide steroid tapering. Academic endocrine research refines ICU protocols. This restores critical metabolic equilibria. And now we will consider Activity 18, drug shortage mitigation. Early identification of shortages is achieved through supply chain monitoring. Develop therapeutic interchanges, like lorazepam for midazolam. Ensure alternatives maintain comparable efficacy and safety. Communicate changes to clinical teams via alerts. In vast 2,000-bed facilities, strategic stockpiling mitigates impacts. Research quantifies shortage effects on patient outcomes. This maintains uninterrupted pharmacotherapeutic care. Next, we will discuss Activity 19, patient and family education. Clearly explain each medication's purpose and mechanism. Detail potential side effects and monitoring parameters. Encourage questions to promote post-discharge adherence. Utilize plain language, avoiding jargon. In ICU settings, engage families as patient advocates. It also entails academic development of educational materials like pamphlets. This empowers informed participation in recovery. We will now shift our focus to Activity 20, Quality Improvement Initiatives. Lead systematic audits of medication utilization patterns. Implement protocols to curtail prescribing errors. Contribute to institutional guidelines via committees. Employ Plan, Do, Study, Act cycles for iterative improvements. In academia, disseminate findings through publications. This elevates standards of critical care pharmacy practice. Next, we will talk about Activity 21, Research and Scholarly Activities. Design studies evaluating pharmacotherapy interventions. Collaborate on multi-center randomized controlled trials. Publish peer-reviewed articles in journals like Critical Care Medicine. Showcase findings at international conferences like IFP and ACCP. Mentor pharmacy residents in research methodologies. This generates foundational evidence for evolving practices. Finally, let's discuss Activity 22, Formulary Management and Cost Effectiveness. You should do rigorous evaluation of new drugs for inclusion. Advocate for cost-effective generics over brands where they are equivalent. Balance therapeutic benefits with budgetary constraints. In expansive academic centers, analyze utilization data for savings. Research value-based pharmacoeconomics in ICU settings. This optimizes resource allocation without compromising care. And there you have it, my dedicated viewers. The intricate life-saving symphony of the clinical pharmacist role in the high-stakes arena of critical care ICUs. From the dawn-hour chaos of medication reconciliation to the cutting-edge frontiers of research and formulary mastery. We've peeled back the layers to reveal how these unsung heroes turn potential disasters into triumphs of precision medicine. If today's deep dive has ignited a spark in you, whether you're a front-line intensivist, a budding pharmacist, or simply someone passionate about the miracles of modern healthcare, remember, knowledge like this doesn't just save lives, it empowers them. Thank you from the bottom of my heart for joining me on this journey. Your time and attention mean the world, and together we're building a community that's smarter, safer, and more inspired every day. Now, if this video has armed you with insights that could change how you view critical care, or even sparked a conversation in your own circles, let's make it go viral. Smash that like button if you're ready to champion clinical pharmacists everywhere. Subscribe right now for more in-depth explorations into pharmacotherapy's front lines. And don't forget to hit the notification bell so you never miss an update. Share this far and wide with your colleagues, students, or anyone who needs to know the real MVPs of the ICU. Let's flood the feeds and spark a revolution in awareness. And drop a comment below. What's one takeaway from today's video that blew your mind? Or what topic should we tackle next? I read every single one and can't wait to hear from you. Until next time, stay vigilant, stay informed, and keep pushing the boundaries of excellence in healthcare. This is Health Gurus signing off. See you in the comments and in the next video.